So back to the internship, whenever I would go there, a lot of the MDs were even just like, I wish I just would have done PA school. Like, I should have just been a PA. And even a lot of the PAs I met there, they would say, like, I love being a PA. Like,
hi guys, hey, welcome to epA-eShadowing, everyone. As you all know, I am Rodalyn. I'm the host of epA-eShadowing, and today we have Fabian here with us. Fabian is a urgent care PA. She's been a PA for over 3 years now. So I'm excited to have her, get her insight, ask her some questions, and have her present some amazing case studies today. Thank you so much, Fabian, for coming.
Yes.
So, of course, Fabian, we always start off with wanting to know more about your story. Can you tell us how you found out about the PA profession, why you chose PA, and how you went about like getting your hours and applying to PA school?
Okay, so hey everyone, I'm Fabian, like Rodalyn mentioned. So yes, I've been a PA for 3 years now, just turned 3 years in December, which is crazy to say. So initially going into undergrad, I wanted to be a pharmacist. I was always on a health or pre-health track. My major was health sciences in college. And yeah, so I was going to be a pharmacist. I did a whole pharmacy internship. I hated it. It was mad boring. I just did not really care for it. So then I did another internship, but this time I was actually shadowing physicians, doctors, and it was like at a family medicine clinic attached to a hospital. So at the internship, that's when I first got exposed to like PAs, things of that nature. And then I also had a class with my major. Again, my major was health sciences. So with my major, one of the introduction classes was Intro to Allied Health. So every week, every Friday, they would have someone come in from a different profession and talk about their profession, why they like it, X, Y, and Z. So a guy came in, like a middle-aged guy came in, started talking about the PA profession as well. And he was basically hyping up the profession. And I was like, wow, this kind of seems like what I would do. So back to the internship, whenever I would go there, a lot of the MDs were even just like, I wish I just would have done PA school. Like, I should have just been a PA. And even a lot of the PAs I met there, they would say, like, I love being a PA, like being a PA is great. So I would hear so much job satisfaction. So that's how I got introduced to it. Once I saw that I wasn't going to be a pharmacist anymore, that's when I switched over to the PA route and started to try to find PAs to shadow.
Sorry. So at what point was this? Were you like in like freshman year and you had enough time, or was it like towards your senior year and it was kind of crunch time and you had to figure out, oh, how am I going to get in within like the time frame that I want? So what did you do following, this realization?
So initially, freshman year is when I had the introduction class for my major. So that's when I first got the exposure. And I was like, okay, this is cool. But I still was sticking with the whole pharmacy route. It wasn't until my junior year of college, junior year of college is when I did the internship. And that's when I was like, okay, I'm going to get serious about applying. So really, it wasn't until my senior-ish year. The issue with this is I did already have all the prerequisites, again, because I was a science major, but I didn't have any clinical experience because for pharmacy school, you don't need that. Mm-hmm. So I did have to take a gap year because I planned on doing PA kind of late. So I took a whole year to work as a patient care tech on a labor and delivery floor.
Okay, nice. And I'm glad you said you took a gap year because a lot of students are worried about that. Gap years when it's completely fine. I took a gap year. She took a gap year. A lot of PAs do that on their journey to becoming a PA.
Yeah.
So how long did it take you to get your certificate, like to be a PCT? And how many hours did you accrue upon applying to PA school?
Okay, so for me, luckily, and I guess a lot of you can try to see if you can find this in your area as well. So I went to college in Orlando. Of course, I decided to move back because I was a broke college kid and I didn't have any coins. So I was moving back home. So I started applying to different positions back home. And luckily there was a hospital that trained patient care techs or CNAs, whichever term works best for you. And upon after training, they did a 3-week training. And after that, they would give you a job on the floor. So initially I did the 3-week training. They offered me the job or whatever. They gave me the 3-week training and then they offered me a position. So initially I was PRN on like a med-surg tele floor, and then a position opened up on the labor and delivery floor. So I had to interview for that position as well. And then I guess the staff liked me on that floor as well. So that's when I started working full-time for labor and delivery. So I ended up, because it kind of took me a little bit longer to get the full-time position. On applying, I only had like 500 hours because I was like, you know what, I'm just going to try. If I don't get in this year, I'm just going to try again next year, but I might as well like try and see. So I applied with 500 hours, and I want to say at the end of it, I had like near 1,500. I didn't have the 2,500. I had like 15 something. So yeah.
So you got into FIU, right?
Yes, so I got into FIU.
So that's the only school you applied to, or did you try applying to schools that kind of recommended more, or?
So I applied to 5 schools. I ended up applying late again because I didn't have any hours. So even though I was trying to push my luck, I didn't want to push my luck too much because you still have to pay for these programs. So I only applied to 5 schools. A lot of the schools that I did want to apply to, I missed their deadline or I didn't reach their hours requirement. So yeah, I applied to 5 schools. I got into FIU, got waitlisted into 1, and then denied from 3.
Oh, wow. That's a blessing, though, that you got in, especially your first chance at 500 hours.
Right.
So, okay. So how was PA school? How was it from, like, your hardest class of school, didactic first, and then clinical year? So how was didactic year from, like, your hardest class, the easiest class, your favorite class? How was it transitioning from, like, kind of learning in college to now being in an actual healthcare program?
It was definitely a change for sure. I feel like even my hardest class in college did not compare to PA school. And I guess because in college, you'll have like 1 hard class or 2 hard class or even let's say 3 hard classes. But in PA school, I felt like every class was hard. Like I didn't have like a cushion class. Which you can kind of get in undergrad. And for didactic, I want to say my hardest class was probably cardio, pathophysiology, and pharmacology, of course. So with pharmacology, you're basically learning like the mechanisms of drugs, how they affect the body, drug interactions, like a list of things. So that's one in itself, very crazy. And then of course, cardiology, the cardiovascular system is just like Rodolin, you know yourself, like it is a lot. So for me, didactic was crazy. Like I feel like didactic was just rough. Like I want to say like I barely made it through didactic. That's being completely honest. Clinical year to me, I loved it so much more. For clinical year, I think what made it better was the fact that you have one topic or a subject matter that you study for that 1 month and then you move on, or for 6 weeks or however long your rotation is. So if we're doing emergency medicine, I'm just studying emergency medicine for those 6 weeks. I take that 1 test and we're good, versus having 5 tests in a week or having, 8 tests in a 2-week time frame or whatever. So I love clinicals like way more than anything.
Right. So what was your favorite rotation, or the one where you, I guess, learned the most or got the most out of?
So my favorite core rotation, let's do that. Favorite core rotation was OBGYN and emergency medicine, for sure. Emergency medicine, I had a blast. I did the most procedures. I learned the most there. Like it was literally the best. Like that made me want to do emergency medicine. I loved emergency medicine. And for GYN, I had like such a great preceptor. So I did a lot of like women's health exams. So it was like really good experience. So I love GYN as well. for my elective rotation, my favorite elective rotation was probably dermatology. So I'm like open to doing derm as well. I really like dermatology.
Okay, awesome. So we're gonna start answering some questions that you guys may have. Just always gonna be in between, me asking her questions. So somebody asked, what do you think made your application stand out the most?
So I think what made my application stand out the most, probably my personal statement and I would say probably my grades too, because they brought that up in my interview. So for my personal statement, because I get a lot of questions about personal statements, what do I say, I feel like a lot of people get hung up on saying, oh my gosh, I want to be a PA because you can switch specialties and X, Y, and Z, like the main thing. Mm-hmm. And for me, I more so basically showed a story about this woman I met while I was being a patient care tech, and basically me caring for her like over a period of like a month, and basically how our relationship grew and all the things I had to do to take care of her. So I kind of like made it a story in my personal statement about how our relationship blossomed and how that made me want to be a healthcare provider and ultimately wanting to be a PA. So I think that's because they even brought that up and they're like, wow, like the way you wrote it was like different from other personal statements that we typically read. And of course I did include like, oh my gosh, I want to be a PA because of X, Y, and Z, but also I intertwined that into basically the general story of what, my passion is and what made me want to be in medicine in general. Then for my grades, like even for my grades, I still remember to this day, which is crazy because I don't remember a lot of some parts of PA school and even my interview, but I remember in chemistry and orgo and all this other stuff. So I'm one of those weird people who loves chemistry. So I used to always do chemistry, well in chemistry from like high school, college, everything. So that too.
Yeah. Awesome. I was let me see if I have any other questions. Okay. We can answer that later. Did you work under a PA in that unit, the OBGYN unit? And did you get a letter of recommendation from working in that unit?
No. So in the labor and delivery floor, I was a patient care tech. So I did like vitals. I treated the moms after they would have the baby, basically. Where I did get my PA recommendation from is, like I said before, switching over labor and delivery, I worked on a med-surg unit. So one day I ended up meeting this cardiovascular PA there. Like you just have to really network and be really mixy and facey. And that's pretty much what I was doing because I really, really wanted to shadow a PA and I really wanted to get a letter. So I ended up meeting this cardiovascular PA on the floor one day and I really told him like, hey, I'm really trying to get in PA school. Can I shadow you? And he was like, yes, of course. Like I know how hard it is because his daughter at the time as well was trying to get into PA school. So he ended up letting me go to the OR with him on several occasions and, when they would go around on the floor. So then after like a month or so of shadowing him, again, I was just like, I'm trying to get into PA school. So a lot of people would wait a bit longer. And normally now I probably would have been a bit more shy to do it as well, but I was just on a mission. So I asked after a month and I was like, hey, I'm trying to get in PA school. Like, do you mind writing me a letter? And he was like, no, of course. Like, I'll write you a letter. Like, it's great. You've been great. Like, you've been asking a lot of good questions. So, that's where I got my PA recommendation letter.
Nice. Thank you so much for that. And just to touch back on the personal statement, I just want to know, of course, it sounds like you did a great job at telling your story and standing out. One of the best ways to stand out is to just be real, tell your story. Don't think of doing anything generic. Just do a really good job at telling your story and then have that be reflected in the interview, which she was able to as well. So whatever questions they asked her from the personal statement, she was able to, go back and, touch back on what she wrote in her personal statement and really show that it was genuine. So, yeah.
Right.
So, okay. Now we're going to move on to you. I know you guys have a lot of questions. I'm trying to answer them. But we're going to move on to discussing when you graduated. So you graduated in 2018. How was it like graduating course, it was a great experience to be finally done with PA school and transitioning to the work life and starting to work, to treat patients. But how was it, like, finding a job?
So transitioning from PA school to like real life was very difficult for me. I feel like I always had a plan from like high school to college to wanting to go to PA school. Like I always knew what the next step was going to be and like how I thought everything was going to play out. So for me, leaving PA school, I was like, okay, like I'm going to stay in South Florida. For people who don't know, I'm originally from South Florida, like born and raised. I only left South Florida to go to college, and I still went to college in Florida, just not South Florida. So I was like, okay, I'm going to stay in South Florida. I'm going to get a job. I'm going to stay here for like whatever, save money because I have loans, whatever. South Florida is super saturated. So anyone who is living in Florida now, I just want to let you know that, not to be discouraging, not to say that you're not going to get a job. But for me, it was very difficult because one of the specialties that I wanted to do, two, because not only competing against the people who I'm graduating with in my class for a job, but other PA schools in the area, because we had like Berry, we had now FSU has a program, USF has a program, like multiple schools opened up. Nova has like 3 or 4 programs. So we had multiple PAs graduating at one time, nurse practitioners, and like nurse practitioners can graduate like this because their programs, most are online. So it was a very difficult finding the first job. I ran into like so many issues, which I'm going to be talking about further, like not on here, but I guess like on other platforms. If you guys are interested in that, do's and don'ts when you're trying to find a job. So it was like really difficult. It took me a while to find a job, especially a job that I was like comfortable taking. And that's like the truth for a lot of people now that I'm hearing who are graduating right now.
Yeah, it really depends on where you're starting out. Like you said, Florida was super saturated. So, yeah. And I know Fabian, this is Fabian's second time on eshadowing. She's been great in the past. And before you were in pain management. So yes. What made you transition? Was it like you wanting to leave Florida? What made you transition from pain management to urgent care?
So as I was saying to you guys before, like after doing my emergency medicine rotation, I always wanted to do like emergency medicine or urgent care or just something that had like more diversity and more procedures. But with pain management, you can do a lot of procedures. Mm-hmm. So what made me want to switch is, one, to be quite honest with you guys, I never really wanted to do pain management. I just kind of fell into it and it stuck. One, it's easy to get a job in pain management as a new grad. Two, you get paid beautifully, but you have to do a lot. And I mean, put up with a lot. But so it worked for me at the time, but I always wanted to do something different. So with pain management, you have to understand the type of population that you're going to be treating. And that's as far as like, okay, I'm just going to give like a story. Yeah. Okay, so
it might be direct.
So I had, this was a pain management story. I had a woman come in. Basically, to give you guys a rundown, anyone who has to come in for pain management, they have to give their urine. You do a urine sample because you have to do a drug screening, make sure that they're actually taking the drugs that we're prescribing and not doing any other illicit drugs. Anyway, she came in, she was acting like she was in extreme pain. When I say she was in extreme pain, she was crawling on the bathroom floor to the point like the medical assistants had to come get her in a wheelchair, put her in a patient room. So once we get in there and we're like, hey, like, your urine is showing that you're taking PCP, you're taking this, but you're not taking the medications that are prescribed to you. So you're either failing them or something nefarious is going on. She, of course, was not taking that. Once we said we could not prescribe her medication anymore, she literally picked up her bag and walked out.
Oh my God. Then she was able to walk, huh?
So now she was able to walk. So you have to know that you're going to deal with different type of people like that. And it's just sometimes you really just brush it off. But, you know, sometimes you're also just kind of over that type of pain seeking, or should I say medication seeking behavior. So I always wanted to get out of pain management, but once I was presented the opportunity to go to urgent care, it was even better because that's actually what I wanted to do in the first place. So yeah, I decided to get out of there and leave pain management.
Nice. We have a good question. Someone asked, what was the starting salary back in 2018? It can vary, you guys, based on specialty, but what was it back in 2000 or for you?
It can vary, guys, and I'm gonna try to be as transparent as possible, just so you guys know what to expect and what to, I guess, negotiate for. But I had one job when I first graduated from PA school, offered me $85,000. That was probably my first job offer or my second job offer, $85,000. And then my highest was 120. So the 120, of course, was like, great. I'm like, okay, making all 6 figures. Because as Rodolin knows, a lot of people would always say, like, don't take less than 100K. Don't take less than 100K, which, again, I have a lot of words about that, too, that I'll be sharing on another day. And yeah, so between 85K and 120. So, and that's for all my classmates, like the people who would share how much they were making, it would be between 85 to like 120. I only knew one person making over 120, and one is because of the specialty and location they were living in. So
nice. Yeah. So you didn't go with the 120 or did?
No, I did go with the 120.
Okay. So we'll answer a few more questions, guys, and then we're gonna transition to just talking about urgent care, a day in the life with the patient population in urgent care, how crazy it is in urgent care. So one more question. Let's see. Well, this is a good one. So, being that you transition from pain management to urgent care, someone asked, how do you change specialties, or if you can kind of, more so explain, how easy, if it was easier or not to change specialties going into like pain management, which is kind of specialized, and urgent care where it's kind of like ER where you see everything.
Mm-hmm. So how was the transition, or like how do you change? Because changing is easy. Luckily for a PA, it's easy as like, okay, this job offered me a position now, so I'm just going to leave and go to the new job. Like for PAs, you don't have to do like a fellowship or residency. So like I'm working in urgent care today. If tomorrow GYN or an OB says, hey, we have a job here, do you want to work for me? Just like that, I can be an OBGYN PA. As far as the transition goes, it was definitely a learning curve, because with pain management, you get so used to seeing one specific, well, not one specific, but you kind of have like a limited amount of things that you see every day. Of course, sometimes you get a couple of outliers, but for the most part, I'm going to be seeing people with back pain, someone who was in a motor vehicle accident or who fell off a building and they have now neck pain, or, some type of pain, or something was broken, or some type of nerve pain. Like, so you kind of have like a basic, knowledge of how you're going to treat someone almost every day. And then of course, for pain management, you have a schedule. So I know who's coming in every single day, and I know what their issue is. Versus urgent care, people can come in with anything. Like today I was seeing people and I was like, what is going on? Like, why are all my people coming in super sick or crazy? Like, and it's really a learning experience, because I'll remember something from PA school like 2 years ago or 3 years ago, however long ago I was in PA school. And I was like, oh my gosh, like why do I remember? Oh, maybe it's this, like from PA school. And then I'll look it back up and I'm like, oh my gosh, it is this or whatever. So with urgent care, I feel like I get more diversity. It's more fun. I get to do other procedures besides doing like injections and things like that. So definitely it's a learning curve, but it's easy if you just want to change another specialty to another specialty.
Yes, she hit it right on the dot, you guys. Okay, so we're gonna move on to discussing urgent care. So I don't know, will everything about urgent care be in the PowerPoint, or do you want me to like kind of ask about day in the life now, or?
I didn't include a day in the life. I kind of more so included like case scenarios in my PowerPoint. So yeah, you could give like a day in the life type of feel.
So how is it like from when you clock in to clock out? And what she said, excuse me, what she said is correct. Like, you know, you just kind of never know what's gonna walk through those doors. I do urgent care as well. And sometimes, you know, like she said, as far as like pain management, you know, you have a set schedule, you know, how many patients you're gonna prepared for that. You know, when you're gonna leave, relatively. But urgent care, if you sometimes you guys close at 7 o'clock. Well, as far as ours, like we take patients up until 7 p.m. So if we're closing at 7 and someone walks through the door at 6:58, you can't say no. You know, you have
to see them. Exactly.
And then you probably won't end up leaving until like 8 o'clock or 9.
Right. You don't know what you're gonna end up with. So yeah. And it's always the people who have to like have the most extensive workup who show up like 1 minute before the door is supposed to lock and close.
Yes,
so
yeah, definitely. So what is your patient population now? I know you're living in DC, so how is it working in urgent care? What are your hours like? What kind of patients do you
Okay. So as Waterland mentioned, I live in DC. So I work in the DMV area, meaning I work in Maryland as well. For my home center, because I work for a large urgent care system, should I say. For my population at my home center, I do get like more sick and like underserved population. And that's just because like that area doesn't have like, they don't see a primary care or don't have a primary care. And they do sometimes wait a bit longer to come to get checked out, and that's for several reasons. So for me, my population, I will definitely see people like you'll see in my PowerPoint, a couple of people that, you know, will have either heart issues, asthma exacerbations, thyroid disorder, hypertension, like genuinely need to be followed by a primary care. But I kind of like doing that because it really sharpens my skills. Like every day I feel like I'm learning. I don't feel complacent ever at my job. Every day I'm feeling like, wow, I learned something new today and now I can take this on for another day. So what a day in the life. Like for me, my urgent care is kind of different. Our hours, we don't have to do a set 12-hour shift. So you can do like a half day, which sometimes is nice because you can get out earlier. But our hours are 8 to 8. So you can end up working that full 12 hours, 8 to 8. Or you can end up working 8 to 10 if somebody walks in at like 7:59 and it takes, you know, us till 10 to see them. So I go into work. Let's say if I do a full day, if I'm doing a full 12, I'll go into work at 7 something so I can prepare for the day. 8 o'clock, I'm looking at labs from the day before. So sometimes, even though it's an urgent care, I still will put in like, let's say a lab like amylase or lipase or something. We don't get that the same day because it's not done in-house. It has to be sent out to like LabCorp or something. And if I want to follow up on a patient, I'll go look at labs I saw the previous day. Or same with an x-ray. Like sometimes you'll look at an x-ray, but guys, x-rays are very subjective. Well, they're not very subjective, but they can be subjective. So I'll think something and then I'll tell my attending physician and they'll be like, maybe, but then the radiologist will have like the final say. I don't know if that happens with you, Rodalyn.
Yeah.
So I'll go back and look at like older x-rays. And if like the radiologist saw something that I didn't see, I'll go back and study the x-ray. That's a way for me to learn to look at x-rays better. So I'll do that until they register my first patient, depending on how people are trickling in. Sometimes I'll see my first patient either at 8:15 or 8:30. So now for the last 4 weeks before this week, it was like a lot of COVID testing. So you would see people coming in, cold, sore throat, this, that, whatever. As of now, I've started to get I want to say real cases again with people besides upper respiratory infections. So depending on what comes in, that's determining whether we're going to do labs, imaging. I'll go do a physical exam, or sometimes, you know, you wait to get the labs back to go do your physical exam, however it works. So for my urgent care, luckily, Because you'll see if you're trying to do urgent care, some urgent cares only have one sole provider, so you'll probably be a PA by yourself there, which a lot of PAs do well with that. I love the fact that now, since it's my first urgent care job, I always have another provider with me, whether or not that's a NP, PA, MD. This is something else I might talk about at a later date with jobs and, basically them giving you proper training. But again, that's another conversation. But yeah, so I'm always working with another provider. So I'll take about 6 rooms or sometimes a little bit more, and then another provider will take the same amount of rooms. So I'll be balancing up to 4 to 6 patients at a time. And you basically have to be good with time management, organization, remembering your patients. Because you'll probably have, like I said before, when it was like a lot of people with upper respiratory infections, you'll have this person who, oh my gosh, I had cough, cold, and I am vaccinated for COVID. And then this person, you have to remember that, no, I had vomiting, headache, and a cough, and I'm not vaccinated for COVID. And you just have to remember, all of your patients, remember what's going on. Great time management. Rodden will tell you with urgent care and emergency medicine, they are very, what would I say? They really want you to see like the most people you can see in an hour is what they want you to do. So really, my job, honestly, if you could see 4 or 5 people in an hour, that's what they want you to do. So I don't know if that's the case for you, Rodalyn. But yeah, so with urgent cares and emergency medicine, it's all about productivity. They want to see how you can bang those number outs because, of course, healthcare is also a business, so they want you to see like a lot of patients at a time. So you definitely have to be great with like time management and things of that nature. So of course, ideally, if you do 3 12-hour shifts, so 8 to 8, that would be
that's exhausting.
A full schedule. Yeah, exhausting. But that's a full week schedule. Again, for my urgent care, like I said before, you don't have to do full 12s. And just because it works better out for staffing, we don't always get 3 12s. So like this week, I'm working 5 days. I worked today. I worked Sunday. I'm off tomorrow. And then I work 2 more days this week or 3 more days. So yeah, so I'm working 5 days, even though like one day I am working a 12, but that's just because we're also very understaffed. So for the most part, for most urgent cares, you work 3 12-hour shifts if you are full-time. For my urgent care, you can do 3 12s, but more than likely we don't do that. I usually work like 5 times a week. So yeah.
Nice. Yeah. And then for those that want to get into the ER, urgent care is a great stepping stone to ER because you see a lot of the same things. And the only thing with urgent care is that it may not be the best to start off with, like as a new grad, if it's a sole provider practice, because as a new grad, it's a lot to do all that with no backup. But if you like start in urgent care and you have good support, that's great, and you'll have no problem getting into the ER. So yeah, and yeah, Fabian works a lot, but I'm sure she's getting paid like overtime and extra money for seeing all these patients.
Rodalyn knows I work a lot, but in my defense, they also asked me to pick up because we're very short staffed.
Yeah.
And one of the reasons is because of COVID. Like either a lot of people are coming in because of COVID and a lot of staff is calling out because of COVID. So I'm saying 5 days, but really I work like 6 days a week a lot of the times. But it's my doing because I don't just say no, which you can say no. Like I don't think you ever have to like kill yourself off because you don't.
I never said no.
Right, exactly. Rodalyn knows, like, we will just like work because you just end up seeing the money. You're like, forget it. I'm just gonna like do it while I can because I don't have like kids or anything. So
exactly.
I just do whatever. Somebody did ask an important question that I am going to answer because it's pertaining to a day in the life. They asked, do I get a lunch break? Which I think is so me personally, I always have to eat. Like I don't care if it's like for 5 minutes, 10 minutes, I always have to eat or I'm gonna be like bitter the whole shift. And I just can't, I don't know, I just feel like I can't think straight. Yeah. So I always have to make time to eat. I don't know about Rodelin, but for us, we don't have built-in lunch.
Yeah, we don't have. It's like take it if you want to, or take it. You kind of have to make your own lunch, or give time to take it. If you don't, it's not going to happen.
Yeah. Right. So every time I literally just choose, like, you know what, I'm waiting for all my labs right now. I'm just going to go and get lunch right now. And then I just go. Versus when I was in pain management, I would have like an hour, sometimes an hour and a half for lunch. Yeah. And it was built in, like no one was scheduled during that time.
Yeah.
So that's another thing that you have to consider, what's important to you when you're choosing specialties. Which again, I have more to talk about this, but at a later date.
Yeah, listen, because we have so many questions that we didn't have time.
I feel like, okay, so would you guys be open to doing a live with me and Rodelin? Well, Rodelin, would you be open to doing a live?
If you guys want a live, we can do one, like us two.
Where you guys just answer questions.
I feel bad we have so many questions, but we have to move on to the case studies. But if you want to do a live, we can coordinate one. I put my both our Instagrams here. I'll put Fabian's PA package, and then mine is. Oh, everybody's saying yes.
Okay. So yes, guys, if we do this live, show up, please. Ask all your questions because we'll answer it. We'll do it for like an hour or so, and you guys can just ask whatever questions, and we'll answer. And because I know a lot of people want to have their questions answered, but it's hard to fit it in the time.
Sorry,
with like the case.
Yeah, the time constraint. I can't answer every question, but the live will, make time to just be strictly questions and have time. So. We'll follow our social medias, because then we'll post when it's going to be in the time and all the details. So I put our socials in the chat. So yes, thank you so much for suggesting that, Fabian.
Yes, we do that.
Alrighty. So we're going to move on to the case studies, guys. Fabian has a great presentation for you guys. I'm gonna start the case study. Is that fine?
Yeah.
Okay. Alrighty. So can you see it, Fabian?
Yes, I can see it.
Okay.
So everyone can see the PowerPoint, right? Okay.
All right, guys. We're gonna start the case study, but make sure you follow us. Here, I'll put it again. I don't know how to pen, but I'll be in the chat looking at stuff and talking to y'all. But Fabian's gonna start the case study, everyone.
Okay, so a day in urgent care. So also, guys, I do have a DMSC, that's a doctorate in basically medical sciences. It's a PA doctorate, which I will be talking again about at a later date. So case study. So of course, medical professionals are lazy, so you're going to see a lot of abbreviations. I'll just say what they are. So this is a 31-year-old male complaining of shortness of breath for 4 weeks. So whenever someone comes in for something and they say that they've had it for like 4 weeks, 4 months, a year, I'm always like, okay, so what made you come in today out of all days, out of the time span? So he stated that it started to get worse this past week. That's what made him come in. PMH, that's past medical history. Past medical history is hypertension. So that's all that he said. So he has had hypertension in the past, is currently not on medication right now because he said he went to India and China for like 3 years and never ended up getting medication over there. So next, after someone comes in with their complaint, they tell you their past medical history, the MA, or sometimes in the ER, you'll have an ER tech or a CNA, a patient care tech, whichever. They'll take the vitals. So his vitals, blood pressure was 187 over 151. Temperature was normal, 98.9. O2 or pulse ox was 98 and respirations 18. Pulse 111. He weighed 280 and was 5'4". So for this patient complaining of shortness of breath, the labs that we would get: CBC, BNP, UA. So UA is a urinalysis. BNP, basic metabolic panel. Great to tell you about basically one, kidney function, glucose, things of that nature. CBC, complete blood count. And then for imaging, we would do X-ray, EKG. So if someone's complaining of shortness of breath, you would think the respiratory system or the cardiovascular system. So the heart or the lungs. Something has to be going on with that, or that's the initial thinking. So next you would do your physical exam. Physical exam, you would be looking, of course, like I said before, cardiovascular and respiratory. So you would be thinking about the heart sounds. Does this person have a murmur? Their rate and rhythm. So is a person tachycardic, meaning like, is their pulse beating faster than normal? JVD, all the stuff you'll learn in PA school. Clubbing of the fingers, breath sounds, you'll look at their chest cavity, the position of the trachea, all this stuff when you're basically looking at them at face value. So the things that stood out with his physical exam is that he had irregular rate and rhythm. So in PA school, you're going to hear the infamous lub dub, things like that. And it sounded like he had a distant heart sounds. And when we say distant heart sounds, usually when you put your stethoscope, it's like a clear, distinct sound. And it sounds like, it shouldn't sound far. So when I say distant heart sounds, it sounded far. Normal breath sounds. So when I say normal, meaning no like wheezing or crackle. So if someone has like asthma, a lot of the times you will hear wheezing when you put the stethoscope towards their lungs. Pedal edema. So on examination, that was something that I noticed too, is that he had pedal edema. I'll show a picture of that coming up. And then also when someone is experiencing something with the respiratory or cardiovascular system, you would want to do like an abdominal exam, just because they're all intertwined. You don't know if something's going on with the liver, the heart, they're all connected. So but that his abdominal exam, so meaning the abdomen was normal. So bowel sounds were normal. They weren't hyperactive. He wasn't having pain when I pressed down on his abdomen. It was soft, non-tender. Non-tender, no abdominal distension, things like that. Which again, when you guys get to PA school, you're going to learn physical exams. So all of this is going to come full circle and you're going to know more of what I'm talking about. So in the picture to the left, that is pedal edema. So literally you press down on someone's foot or their leg. And when you lift your finger, you'll still see like the indentation in their foot or on their leg, which is crazy. But that's just showing that you have a lot of accumulation of fluids in either the legs or the foot, which is an indication that something is going on with the heart, and you have somewhere being congested. So this x-ray, this is an actual x-ray of this person's chest. So I actually took a picture of it. Of course, all of his information is taken out, but I wanted you guys to see an actual image of the x-ray. And yeah, so if anyone can tell me what is going on with this x-ray that had me a bit concerned, it's okay if of course you don't know. I still learn every day how to read x-rays. Okay, yeah, I see this. So someone said congestive heart failure. So yes. But at face value, you would just say cardiomegaly or like a large heart. So yes, so basically his heart is taking up so much of the chest cavity. So that is sometimes an indication of congestive heart failure. So shout out to everyone who knew that. Yes, the heart is very large. So once I got that back, I was like, okay, there's a lot going on. So EKG, I also got an EKG done for him. I thought I saved the EKG, guys, but clearly I didn't. So I'm just showing an EKG on the left that shows heart failure. And he had an abnormal EKG as well. To the right is when you have normal sinus rhythm. That's how they typically look. That's when, the heart is conducting normally. So yeah, so he had an irregular EKG as Someone said the heart is not that massive. Yeah, that's the heart, the large white section. So then we also got the labs back. So for the CBC, white blood cell count was normal, RBCs was normal. His hematocrit and hemoglobin were lower than normal for a male. So I could also even say that he has like iron deficient anemia. For the BMP, it did show that he had an increased glucose. So his creatinine, the creatinine is a good indicator of renal function. So his was higher than the normal baseline, which again, like I said, the abdomen and the heart and the lungs are all intertwined. So sometimes when you have one issue with one organ, it spews out to the next one. So yeah, so he basically had renal insufficiency, a high glucose count, but this was like in the midday. Usually when you do a BMP, you want to have the person fasting. This was midday, so it's not necessarily that great of an indicator for that, but still a bit elevated. Because really it should be under like 109, if I'm remembering correctly. Yeah, like 109. So yeah, treatment plan. So this guy, he had to go to the emergency room. So a lot of times if you're working in urgent care, you have to make that decision whether or not you're going to send someone to the the emergency room, if you're going to send them to a specialist, or if you're going to treat them in the urgent care. So this person, I wasn't playing any games because I don't play when it comes to my license, and you shouldn't either once you get yours because you're going to have to bust your butt for it. So because he had one shortness of breath that worsened over this past week, he had cardiomegaly, an abnormal EKG, renal insufficiency, and hypertension emergency. So if you go back to that slide, like at the very beginning that I can show you, his blood pressure was like 180 something over 150 something, which is very, very alarming because you do not want any of these patients to stroke out. Especially, I don't know how long he's had this hypertension, how long it's been running this high, especially because he said he was diagnosed years prior, but he hasn't been taking any medication. Someone said, how long does it take for you to get labs back? Depending on who works in the lab, to be quite honest. Some lab techs are so quick because they've been doing this for years. So it's like I get the labs like literally under 30 minutes. Sometimes you have to wait a bit longer. Also, if they have to centrifuge something, again, it takes a bit longer. So all depends, but for the most part, I can get it back in like 30 minutes. So yeah, so because he had all these things going on, he had basically like, I could give him like 5 diagnoses at this time. He had to go to the emergency room, like send him off. So I sent him to the emergency room. Again, also you guys are going to have to make the call when you want someone to go to the emergency room, whether or not you're going to call EMS. So the thing with EMS, if someone isn't actively dying, they don't want you to call them. And if you call them and someone isn't actively dying, they'll just look at you stupid and they'll be like, why did you call me? So for him, I honestly told him to drive. Why? Because he's been functioning at this base for however long now. He wasn't actively dying. He is, headed towards, death, but he's not actively dying, meaning I didn't think he was going to die within the day. So I let him, just being honest with you guys, like that's really how you have to play it by ear, basically. So for him, I said, okay, do you have someone to drive you? Because he drove himself. He was like, okay, I can call my mom. And his mom ended up coming to drive him. I didn't call EMS. And I guess it was a great call because like a day later, my attending physician came to me and she was like, that patient who you were telling me about who had X, Y, and Z, they ended up, sorry, let me get my charger.
No problem. This is a great case, guys. It's a great, great case. And I was also going to say that, like, as she said, a lot of patients you see in urgent care may be an actual ED visit. So you'll learn a lot of ED type stuff or working up a typical patient.
Yes. So my attending actually came up to me like a day later and she's like, you know, that guy you were telling me everything about or whatever, it's good that you sent him because they ended up admitting him. So he's basically in the hospital right now. He's admitted and being followed by cardiology and nephrology, of course. So yeah. That was a good case. And again, that's just one of the things you can end up seeing at an urgent care. So of course, this was one of the things that walked in that I was like, what is going on today? But very interesting. And again, I learned a lot doing this case. So like that one. Next one is case 2. So I had a 38-year-old woman come in complaining of fever, nausea, vomiting, suprapubic pain, and for 7 days. So suprapubic pain just basically means the part just above the pubic area. So yeah, so she was complaining of abdominal cramping as well. So her vitals, regular blood pressure, temperature was 100.1, oxygen, respiration, all that was fine. So for her, we would of course also do CBC, BNP, urinalysis, and a pregnancy test. So any woman complaining of pelvic, abdominal pain, things like that, and they're in the range of like childbearing range, basically, you just always do a pregnancy test, no matter what they say, just because you never know. So even if it's like a 16-year-old who comes in and is complaining of that, we would have ran a pregnancy test, sometimes even 14 years old. So, you know, you just kind of have to do it because you just never know. So physical exam for this person. So physical exam, again, with the urgent care, you're going to notice that you're going to do focal exams. What I mean by that is that you're going to do basically the systems that people are complaining about or things that are in relation to the system. Because like I said before, you're kind of like, I don't want to say rushing them out, but you're trying to see people as best you can and as quick as you can in like a specific time frame. So for her, again, I wanted to do an abdominal exam and a pelvic exam. So for the abdominal exam, you listen to the sound. So whether the bowel sounds are normal or hyperactive, things like that. You do palpation, meaning like press down on the abdomen to see whether or not it's soft or non-tender, or if they have pain when you press down. You see if there's any abdominal distension. I was going to give you guys that case too, but that person I had to send to the emergency room as well. And I was like, I'm doing too much. I'm going to be calm. But yeah, so abdominal distension, stuff like that. So her abdominal exam was fairly okay, like nothing crazy. The picture that I inserted in this is when you're checking for CVA tenderness. So CVA tenderness is a good indicator whether or not someone is having kidney pain. So people do this to see whether or not with like kidney stones or like other kidney disorders, which you guys are going to see. And then also you can see if the person has flank pain. So that's just the lower area of the side back is what I like to call it. So we also do a pelvic exam. When I do a pelvic exam, I have to get a chaperone. So that either has to be a female nurse or a female tech like MA or whatever. We go in, I can either swab them for, we also do STI screening. So while I'm down there, I can check for chlamydia, gonorrhea, trichomonas. We can also check at the urgent care, BV, yeast infections, things like that. So we did a pelvic exam. You can do a bimanual exam, and that's basically when you check inside of the vagina, see if someone has like cervical motion tenderness, things like that. So with her pelvic exam, she really just had like suprapubic pain with palpation. She did have CVA tenderness on the abdominal exam, and she did have flank pain. Nothing really crazy with the pelvic exam. So for her, CBC's white blood cell count was 15, which was a good indicator of what was going on. The rest of the blood work as far as the CBC looked okay. And then her urinalysis. So the urinalysis with this, you basically get to see color, the pH, specific gravity is a good indicator to see if someone is dehydrated or not, things of that nature. Ketones, nitrates, leukocyte estrates, and WBC. So for her, she had white blood cell cast basically in the urine, nitrates, amber colored. So all of this coupled with her physical exam, and her having a fever initially, I diagnosed her with pyelonephritis. So again, you have the option for her with pyelonephritis. You have the option of sending this person to the ED, depending on how severe you think their symptoms are. And then you have the option of treating them on an outpatient basis. For her, I felt like she had like good follow-up, meaning that I knew she would return if anything were to make a downturn. And I knew she would just come back in the 2 days that I wanted to see her anyway. So for her, I gave her an injection of Rocephin. Rocephin is basically ceftriaxone. It's an antibiotic that you can give an injection of that. So I had the nurse give it to her IM, told her to follow up in 2 days. So that way we could recheck her white blood cell count, see whether or not it has gone down, see if her symptoms have improved. And then, so I basically chose the latter, didn't make her go to the ED, because another thing is the ED wait times are have been very long. Like some people have even told me that they've waited 17 hours, things like that. So unless I feel like someone really, really has to go to the ED, like if I can treat them at the urgent care, I just end up treating them at the urgent care. So for her, pyelonephritis, gave her an injection of Rocephin. A lot of people would say just do 250 milligrams IM. So again, that's kind of like subjective for you again. So that's basically what happened for her. Laura said, can I repeat the name? It's called Rocephin or ceftriaxone. So So that was the case, guys, the second one. So that's pretty much a lot of what I see in urgent care.
Thank you. And Rocephin's my favorite antibiotic, by the way.
You get Rocephin. You get Rocephin.
You get Rocephin. You get Rocephin. It's such a good antibiotic. It's broad.
It works.
Yeah. So, but thank you, Fabian, for the presentation, case studies, for being here today, for coming on and sharing expertise with everyone. They seem to have loved it, getting some great feedback. So thank you so much for that.
So yes, thanks guys. So again, Rodolin did put in both of our socials, so you can follow us on socials. We'll also be on the MedSimbly app as well. So make sure you guys are looking out for that. We're launching in March, April-ish. So just reach out to me on either or, so we can converse on MedSimbly there. And we're gonna try to do the live, guys. So come on the live to get your questions answered, because I know there's so many more that we were trying to do. So I'm so sorry that we couldn't get to all of them tonight.
Yes. Everything Fabian said. So thank you so much, guys, for tuning in. Thank you again, Fabian. So make sure you follow us, guys. So we'll post when we're going to go live. We'll post shortly, soon, about the live date and time. So thank you again. We'll see you guys next Monday. Thank you, guys. Make sure you're following us so you can get all the details about live and MedSimbly and everything going on. So thank you. All righty.
All right. Bye, guys.
Good night, everyone.
Bye.
Bye.